Right, so I've split the talk. I mean, I'm supposed to talk about arrhythmogenic cardiomyopathy as well as myocarditis, so I split them, just separated them. So the second bit is going to be about myocarditis. Obviously, as you'll see, that there'll be a bit of overlap, but yeah, that's how it's going to set up. So when we're talking about cardiomyopathy, it's just very, an introductory slide, which you may probably have seen a million times by now. But it's really about the shape of the heart, so how the heart looks like. And you can see here, this is MRI scans essentially, from hearts. And this is how a normal heart looks like. So this is the left side of the heart. This is the right side of the heart. So this is the main pumping chamber essentially. It pumps all the blood to the heart. Blood comes in this way, goes out. Essentially, it's like two squids stuck to each other, if you want, and they're just pumping the blood. And you can see here, this is a gentleman with hypertrophic cardiomyopathy, so it looks like it's a thickened heart muscle. You can compare to this one. And you can see here somebody with a dilated cardiomyopathy, so which is essentially means an enlarged heart muscle. And you can see here, this is somebody with an arrhythmogenic cardiomyopathy. And you can see here, the right side is quite significantly affected. We'll see some more images afterwards, but also the left side. And you can appreciate here, this image here, it's not particularly much different than that, in some aspects, and we'll see, what's happening in a while. But anyway, so this is, where we're gonna stick, and maybe a bit of that, but it's all about that. So when we're talking about arrhythmogenic cardiomyopathy, what does it mean? I think that's one of the important bits. It includes a few different words in there. I mean, the cardiomyopathy we've sort of tackled. It means it's usually a genetic determined heart muscle disease. That's what cardiomyopathy means from out of Greek. It is associated with a fibrofatty replacement of the right and left ventricular myocardium, so heart muscle essentially. So that's what happens. There's a lot of fat tissue and scar tissue that replaces the heart because of that. And we call it arrhythmogenic because of the increased risk of rhythm irregularities that can occur with this type of condition. And this is just the ECG, which I'm sure you know. Yeah. Now, how common is, and obviously it's a bit to struggle what populations we're always looking into, how we measure things, and I mean obviously we can't really take all the 7 billion people on Earth and check them and see. It's very difficult. So usually what we do is we check some of shorter cohorts, and then we extrapolate data. But we think it's about 1 to 2,000 over 1 to 5,000 of the general population. So really it's part of the rare conditions in general, but it's not entirely uncommon. But if you look into more other populations, such as young people, for instance, and people that die suddenly throughout, and if you look into that, you can see that about 10%, or at least about one tenth of those may be down to arrhythmogenic cardiomyopathy. And you can see here there's different registries, from the UK data from the St. George's, some from the military, US military data, which put it somewhere around there. Now, what are the causes? I mean, we've said it's a genetic condition, so it's an inherited condition. It's part of the genes. And you can see here, these are, the desmosomes, and I'll show you in a moment what desmosomes are. And these are some of the most classic genes that we know, plakophilin, desmoplakin, so, it's a bit of weird names, desmoglein and, desmocolin. And then we've got some other which are not really, the desmosome, but, which are maybe genes that we've had before, which is like lamin, which is a relatively common gene, and filamin C. And then we've got some other more less common genes in that, and quite often we don't find out what it is. I mean we look for it quite hard, but not quite there yet to know all of those. And these are what the desmosomes are. Essentially, imagine your cells in the heart. It's not the heart is consists of many cells, and they connect to each other in a way. And because the heart is a pump, it has electrical activity and has a pumping activity as well. And the desmosomes essentially are the connecting, cells between, or the connecting tissue between the cells. And what it does, it gives the electrical signal from one cell to the other, so that they know when to conduct all at the same time. And these are the various different proteins that are in there, like all this, that we mentioned there, are doing exactly that. So they connect the cells to each other, and they pass on the electrical signal from one to each other. So you can imagine that if something actually is not quite working there, then the electrical signal may be a bit of an issue. And also what they also do is they keep the cells together. So if they are not there, the cells are allowed to slip a bit. Yeah. And those are again the genes that we said more commonly. Now the way these conditions are mostly inherited there, and I think that's one of the most important things, is a 50-50 chance of having the gene being passed on. And you can see here, this is, these are the parents, and these are the children. and everybody has 2 copies of each gene. And what happens is that every child gets 1 copy from each parent, and then they get a mixture. And if you actually have the genetic condition, then potentially you can develop, the condition. So this is what we call a 50, an autosomal dominant inheritance. But, for some forms, like the Knox disease, for instance, you actually need both copies. So this means, 2 parents need to come together who have 1 copy of them. And the chance of 25% is that one child gets both copies from each parent to actually develop the condition. This is a bit less rare to develop. And the other thing that we like to talk about with this type of genetic conditions and inherited conditions is how much, having the gene, we all have, genes. Obviously, do we all get the same thing? We would be looking, exactly the same if we had the same genes. But even twins, for instance, they do have some differences. So really is what the genes are doing with, their expressions, how they look like in the end. And this is what we call a penetrance and expressivity. So essentially, having a gene means that not everybody is going to develop the same amount of condition, but also it will have a variation. Somebody may develop very mild or nothing, and somebody may develop, very severe forms. So that's what it means. Some of those conditions, though, are actually in the arrhythmogenic cardiomyopathy, they are close to 100% of actually expressing something. And these are, for instance, like in Knox disease that we discussed before, and genetic conditions like the lamin, for instance. Yeah. Now, obviously, as I said, having a gene is one thing, but there's a lot of environment that comes into that. And I think, this is where our, game comes from for as well. Yours and ours. So, we're doing a lot with our genes, and this is, one of the theories that says that, a lot plays, what the sex of the person is, how much exercise they're actually doing. And this is particularly important in this type of condition that we're discussing about in arrhythmogenic cardiomyopathy. You can see here, obviously, this, having the gene is only one of the factors, and depending on how many genes or even no genes at all, then it will place the influence of the environment will have a significant or a different role on that and effect. So sometimes if we don't have any gene in the family, for instance, doing a lot of exercise may be even more important than the actual genetic condition. And this is what we sort of discussed about. So having a genetic change in one of the genes there leads to different changes, both electricals as well as structural, and leads both to a slipping of the cells, but also to the electrical signal being interrupted, and potentially allowing for the problem. The heart cells, they are all independently possible to do electrical activity, and what happens is that when they are controlled under our pacemaker, and when this gets interrupted, they are allowed to do whatever they want sometimes, and this is part of the problem. Now there is. So this is a patient with Knox disease. You can see, some of the features, and what we can see here, obviously, but not everybody, we're all born with the same genes, but it does take a while for us to develop, and this is, through a period of, some years and months. And you can see sometimes, there may be a phase where, the condition develops, within quite a relatively short time, potentially depending on what the environment it does, or depending on what the physical activity is, for instance. And you can see here, this is somebody that presented with symptoms. We may present with symptoms, and we'll see what. And then, within a few months' time, to develop the ECG changes and also the fibrosis in the heart. Now, we're going back to how well recognized are things, and you can see here, I've put down all the publications in PubMed about the various names that we'll be giving. Part of the problem is that we have very different names, and we're talking about, back in the days, we used to talk about arrhythmogenic ventricular dysplasia, so that's how it turned up. Now, then it's called arrhythmogenic ventricular cardiomyopathy. Now we're talking about arrhythmogenic cardiomyopathy. And you can see, through the years, obviously the interest and the recognition of things has significantly increased, but also the nomenclature of these, so the names themselves are also changing. This is the first description about arrhythmogenic cardiomyopathy back in 1977, where it was still called people were seeing the ventricular rhythm issues and describing things. And this is the publication, from 1982, where we were talking about dysplasia, so the right heart of the. So when we first realized what it was on the right side of the heart, because that was what we realized. And people were seeing all the electrical abnormalities, and then with all our measures back then and the histology, So that's really, one of the first descriptions when our understandings. And obviously, since then, a lot of research has gone down, a lot of recognition, a lot of different things. And we're now somewhere at the level where we're talking about arrhythmogenic cardiomyopathy. And this is because we realize that it's not only the right side of the heart that is affected, and this is where where the paradigm is really changing. But really, when we actually look into people who have very, very similar problems, which is the electrical instability and potentially the heart failure symptoms, we see that there are different clusters, and some are very, very much focused on the right side of the heart. Some are a bit mixture and again more dominant. And then there are some patients who actually have much more different condition, more affecting more the left side of the heart rather than the right side of the heart. And why is that? And we know, we discussed about genetics. So genetics seems to be one of the most important determinant here. And we know that some of the conditions that we thought, or some of the genes that we thought before were affecting more the right side of the heart. Now we know that they may be actually more on the left side. And I think that's important for what we are, for how we're treating, different phenotypes and different pictures. And you can see here, they all pretty much have the same histology and the same arrhythmogenicity, but they will affect the left and the right side differently. And this is part of the confusion as well. And so here, essentially what we're talking about now is more, right dominant. We can sort of say the classic arrhythmogenic right ventricular cardiomyopathy, the way we described it, or was described back in 1977. But nowadays we realize that's a lot of other things that have a very significant overlap here in terms of genetic conditions, and which look very similar, behave very similar, but may be a bit different. And this is how it looks like. So somebody with a only right side affected. You can see here the heart is enlarged, the right side of the heart. That's a lot of aneurysms. So essentially, the wall is irregular. And you can see here, this is somebody that has both sides of the heart affected, the right side. There's a lot of scar tissue on the cardiac MRI, as shown here by the white and the black. So this is where our current understanding about arrhythmogenic cardiomyopathy has evolved. Now, another part of the confusion is, and this is probably, there's a differentiation between dilated cardiomyopathy and arrhythmogenic cardiomyopathy. And you can see here, this is the enlarged heart muscle. I mean, sometimes we can see it with both sides, and there's a very large degree of overlap, which leads to confusion sometimes, because some people will say, well, I was told I've got dilated cardiomyopathy, and then you go to somebody else and you say, well, you've got arrhythmogenic cardiomyopathy. So that's a bit of confusion that leads. But what is important to realize is that there is a big overlap, and usually the way we differentiate that is on the basis of genetics, essentially, what genes we found. And this is where it actually becomes quite important to find, what the background is. Now we'll go a bit more into symptoms. Symptoms are relatively non-specific, but some of them can be very, very, very more common. People get a lot of palpitations, especially during exercise with arrhythmogenic cardiomyopathy. They can get chest pain, shortness of breath, especially if the left side of the heart is more affected, which pumps the blood to the body. I think that's one that is important, so sudden loss of consciousness. That tends to be a bit more common in this type of conditions, and obviously cardiac arrest. And as we've seen, sometimes people can present actually with myocarditis, which makes things potentially even more complicated. So may present and with this type of condition. So always have to think about that when it comes down to myocarditis presentations. But there are also some findings outside of the heart, and some of the genetic conditions, they are, as we said, they are very important. So some of the desmosomes, the desmosomal genes that we were discussing about, they have other functions outside of the heart. So they connect the skin cells together as well. For instance, you can see here they can change the way the hair looks like. So very typical, woolly hair. You can see sometimes, in the family, a lot of woolly hair, and some skin changes as well, like sort of hard skin. And especially in some of those conditions. I mean, back in the days where Nikos Protonotarios was describing the Naxos condition, which is in an island in Greece, you could go out on the beach and see how the hair looks like and how the skin would look like, and tell the patients to actually come to his office, so that diagnosed just by the extra cardiac findings. And that's a bit more rare, but some patients may have myopathy, so muscle involvement as well. like lamin, for instance. This is or desmin. So these are a bit more rare genes, to see with arrhythmogenic cardiomyopathy, but because they are part of our muscles, the muscles that move our arms and legs, they may actually have a bit of muscle weakness as well. So, that's something to think about as well when it comes down to that. Our role, I think, in the inherited teams and the way, we go around with, obviously we're not talking about one person, we're talking about families. And the way we always go about that is, we've got a tree. We'll start from the diagnosis, obviously, and then we have to assess different parts of the treatment. And when we're talking about diagnosis, sometimes it can be very, very easy. When you have somebody, with all the woolly hair and the skin changes, and we do all the investigations, which can be very, very extensive, starting from just talking to people, getting a history, detailed family history. I think that's very, very important as well. But obviously, very more detailed examinations, such as the electrocardiogram, which will give us a bit of understanding how the electrical activity is going around in the heart. 24 hours monitor. Quite often we pick up some extra bits that come from some areas of the heart. That's important to know. And then we will get some more advanced imaging studies. So we'll see how the heart is pumping with an echo or a cardiac MRI. And quite often we may actually do a stress test as well to see, because some of those, as we said, an exercise, the palpitations and the rhythm issues may be more common. And sometimes, it can be easy, but this is the way we need to diagnose sometimes arrhythmogenic cardiomyopathy, which is, I don't want you to stick on that. I just want to show you that it's very, very complicated, and we need to tick different boxes from a large table. So sometimes it can be more difficult to actually get to the bottom of that. And what we're looking for in our diagnosis is, structural changes. As we've seen before, we see that the heart doesn't look like a normal heart. It looks like a large heart muscle quite often, with potentially scar tissue. And this is our histology, how it looks like when we actually look on the microscope into that, with all the scar tissue and the fat tissue. And also what we're looking for is the electrical activity. As we said, from the ECG and the Holter, we can pick it up quite often. And you can see here some of the changes. So these T waves, in the anterior leads are one of the classic findings in arrhythmogenic cardiomyopathy. They normally should be pointing upwards, but when they point downwards, that's a bit of a criterion that we use. And then obviously when people have arrhythmias, and this is somebody that we present with what we call a ventricular tachycardia, which is rhythm, fast heart rates coming from the bottom chambers of the heart, and is one of the most common arrhythmias that patients with arrhythmogenic cardiomyopathy may face. So when we have this relatively bits and pieces from all different areas, then we know what the diagnosis is. And these are some of the tests, as we said, that we're using. The echocardiogram, how it looks like, and then we're now very, very grateful that our MRI is developing over the years. And back in the days, we were using MRI, but we weren't quite sure what we were seeing, and our understanding and what we're seeing on the MRI scan is becoming even more important. And in fact, some of probably the newer diagnostic criteria which we will be using will have a lot of MRI as well in there, which at the moment isn't quite part of it. So, and as I said, our understanding from 1977 to now keeps changing. And back in the days, people would draw on a piece of paper. I think this is how it should look like, but actually it tends to be a bit more different. So this is an echo of somebody with a right ventricular cardiomyopathy. You can see here the right heart is, it's moving, but actually you can see the actual wall is not really, shortening, it's not really thickening. And you can see here some areas are not really moving that much, even here, so that's the classic areas. You can see here the right side, again, it looks very big. And on the MRI, you can see that it's very irregular and has some fat tissue as well, potentially here, which you can see. So, some of the novel imaging techniques will give us a very good understanding of what is going on the tissue level and obviously about the function of the heart. And we tend to do them, when we got the suspicion, when we got the diagnosis, and then on regular intervals afterwards as a follow-up. Sorry. As we said, genetic testing is increasingly important, in arrhythmogenic cardiomyopathy. And who needs to be tested? And pretty much everybody who is affected with arrhythmogenic cardiomyopathy should have a genetic testing. people who potentially have experienced a sudden death, we tend to do a analysis of genetic testing in the postmortem material if we can, so that we can offer obviously the family potentially screening and testing for that afterwards. And that's quite important both for the individual themselves, and we'll see in a bit why, but also for the family. So really genetic testing is very central in the management. The other very important thing that we talk about, and obviously this is the reason that we that we do all these things, is to assess what the risk is of those rhythms. We said rhythm irregularities and the risk of sudden death is very central, and every time we see somebody, we need to assess what their risk is of that and what we can do to reduce that. And I'm not going to stick very much to that, but we know this is a well-recognized arrhythmogenic cardiomyopathy cause of sudden death. Again, different populations, athletes who've all experienced that. It's a big part of that. Younger populations, depending on where we're looking, obviously, but this is always there. So arrhythmogenic cardiomyopathy is a significant part of causes of sudden death in populations. And obviously not everybody is high risk, and I think that's the important thing to recognize. There are some people who may have very, very few risk factors, and obviously we have the high risk patients who are generally have experienced potentially dangerous rhythms, and these are usually what we call the probants in the family, so people that are the first person that presents and comes to attention because of that. So these are high risk population. And you can see here we've got a lot of risk factors that we look for in our various investigations that we're doing that make us potentially decide, obviously who is high risk or moderate risk and what we should do with that. And you may have heard of it. A couple of years ago we were relatively happy to have a risk calculator. So essentially, everybody can go on the internet on this website. Put their details in there. It's relatively simple. Usually, you can take all this information from the letter. I mean, it's widely available, and it will spit you out essentially a number that tells you what the risk of experiencing ventricular arrhythmias is. Obviously, this is just a risk assessment, but this is very helpful and can be very helpful in various individuals. Now, this is well validated for patients who have significantly who have arrhythmogenic right ventricular cardiomyopathy, not so much for the rest. So bear in mind that there may be a limitation always. If you do that, and I'm only telling that because there's a lot of people that go on Google. Just bear in mind that you should always discuss with some trained clinician to actually assess all these things. And going back to that, so this is essentially what we're talking about, and the way to prevent the sudden death is by potentially implanting a defibrillator. And we'll see in a moment what it is. But again, there are indications for that, and usually the high-risk people should have an ICD. And you can see here this is a class 1 recommendation, which means we've got evidence that says actually this is helpful. It will reduce the risk of sudden death. And then there's a lot of gray zone, a lot of intermediate zone, and this is where we look for various things. And blackouts are particularly important. Some if we see that the left and the right side of the heart are, for instance, impaired in their function, or if we pick up rhythm irregularities on the Holter, then we may, these are all risk factors to consider in the risk assessment. And on the other side, we've got some people who have none of those things, who are considered low risk, and generally an ICD is not implanted. We know ICDs can be very effective in reducing the risk of sudden death, and you can see here there's lots of studies. That's just one from 2010. So the ICD, this is the classic intravenous systems, where we've got a system just under the left collarbone, a couple of wires, one wire going to the right side of the heart, monitors the heart rate all the time. If it does on monitor, if it does pick up any dangerous rhythms coming from the bottom chamber of the heart, then we potentially will do some treatment. And there are multiple ways of doing the treatment, either by pacing faster than the heart itself, or giving an electrical shock and bringing back to the normal rhythm. But we know this is a very effective way of actually treating that. And if I just summarize, who should get really an ICD, and really these are people who had a prior cardiac arrest, who said these are people, I think where we're not really discussing about whether it's going to be helpful. We know they have had cardiac arrest, so so they should have a defibrillator. So most of the times, as we said, these are people that, the first people that come to attention because they tend to have the most significant presentation as well, so usually those people. And then when we check the family and screen the family, some of the members are going to be low risk, some are going to be moderate risk, or obviously high risk, and depending on those, they may need an ICD as well. Now, again, you may have seen, in the developments lately, this is the classic system, wires in the heart. Nowadays, in the last 15, 20 years, we've got what we call a subcutaneous ICD, so nothing is going in the heart itself, so everything is just under the skin. It's a box that comes in the armpit. There's a wire running along the chest wall just under the skin. This is what we call the subcutaneous system. I mean, the benefit with that is obviously we don't have to put anything in the heart. The risk of infection and quite a lot of the risks are falling away. And we know this is quite effective in actually treating, and preventing sudden death in arrhythmogenic cardiomyopathy. And quite often when we can, especially in younger individuals, family relatives, where we can avoid having this type of device, we will stick with this one. Yeah. Now, and I think this is one of the important bits. We've said a lot about genetics. This is a very recent actually study for a couple of weeks ago. So actually looking at the genes itself, it doesn't only give information about the obviously that we can use for the family, but also it gives us more information of how to assess and how to treat a person. You can see here, if we actually go in and we actually look at how the heart looks like, we've got different opinion about, what we call arrhythmogenic and what we call dilated cardiomyopathy. But if we actually split down to genes, and you can see here, sorry, it doesn't project very well, but if you can see here genes like desmoplakin, plakophilin, filamin C, and lamin, which are considered to be higher risk genes than the others, you can see that we can differentiate much better what the outcome, what the prognosis is going to be, what the risk of arrhythmias is, and obviously, what the development may be, and obviously focus much better on our treatment on the high-risk genetic conditions. Equally, if we don't find one of the high-risk genes, we can be a bit more relaxed about it, not meaning that, but we just need to we can use that significantly to assess the risk. So really, genetics is very central in this risk assessment, and it's becoming even more than before. Sorry, and as we said, there's a big overlap with dilated cardiomyopathy, and these are some of the indications. The genetic testing, especially young people, should have it. Some people who have high-risk features on the ECG or on the imaging, with that. And then these are some of the classic indications that fall out of what we discussed before. So essentially, if the left side of the heart is particularly affected and the function is reduced, then we will, there are independent indications and other indications for a defibrillator. Yeah. I think that's to me it's a very important slide, and I put it together because obviously all these, having a defibrillator is not an easy job. And obviously having to discuss all these things here today is not an easy job either. And we know that it's actually, the anxiety and, obviously there's a lot of effect about that. And this is what becomes even more important, to actually be able to assess who is high risk, if they're high risk, if they're low risk. Because obviously, giving a defibrillator may save your life, but having something that is in your body for a while, potentially people may feel dependent on this device. We know it does, cause significant degree of thought and anxiety, and really it's important to actually find out who needs to have it and why. Yeah. Next bit is really to reduce symptoms. We talked about the risk assessment and also prevent progression. We know genetic conditions tend to be progressive. It's not really about getting a diagnosis. It may be slower, it may be faster, but they tend to be progressive. I think one of the important points where people are more interested in, and I keep getting the most questions obviously, and it's part of every consultation, is really the exercise. And unfortunately, the exercise tends to be part of the disease progression. So we know exercise, especially in some of the right ventricular cardiomyopathy, is known to lead to a progression. And why is that? The right side of the heart tends to be, more affected by the exercise. When people exercise a lot, it tends to become a bit bigger. So if you do have a genetic predisposition to that as well, then the exercise may become even more relevant. And then the other thing that we know is also that arrhythmogenic cardiomyopathy and some of the deaths that present at young age and relatively high level athletes. So we keep seeing, quite very active individuals coming up, and potentially because the exercise is so relevant. Yeah. And exercise is really a common trigger of arrhythmia. So as we've seen, in athletes, about 10% of the sudden deaths may be because of arrhythmogenic cardiomyopathy. And I mean, obviously, we'll have a lot of data by now about that. I'm not going to stick much to that slide actually, but I think this is the other important. So these are gene carriers. So essentially, these are family relatives who know they carry the genetic condition, but actually do not have a significant. They don't have a cardiomyopathy per se. So they're just gene carriers. And you can see here, if we divide them in how much exercise they actually do, you can see here that patients that do more exercise tend to develop the phenotype more commonly, more frequently. And equally, also the electrical issues that occur with that tend to be higher with increasing amount of exercise. And this is also true in actually patients who are diagnosed with arrhythmogenic cardiomyopathy. And you can see here, these are patients that have the diagnosis. And when we go back and look how much exercise they've done before, we always find that the ones that did more exercise, they tend to have the more phenotypes, or worse phenotype if you want. But also if they carry on after the diagnosis doing exercise, they tend to have also more arrhythmias. So I think exercise is quite central here, and exercise advice and restriction is probably very important. Now, does it mean we don't have to do any exercise at all, or how much exercise is really safe? And we think it's about somewhere there. So this publication, again, very recent. It looked in individuals how much exercise they're doing and how much their risk is increasing in terms of arrhythmic events or irregularities in the rhythm. And we think about 15 to 30 METs, and I'll tell you in a bit what this means in a week. It's probably safe in all individuals. Above that, it starts becoming a bit more dangerous in terms of progression and rhythm issues. And in fact, actually, remember the calculator that I showed you before, we could use quite well in those individuals, or even in very athletic individuals. We can actually use the calculator and calculate their risk and actually tell them, listen, you're high risk, you shouldn't exercise, or actually you're low risk and, you can exercise a bit more. And these are the current advice, the current guidelines on, how much exercise. And I think it probably should stick into that side. As you can see, the problem is, that ESC tells something different from the American Society of Cardiology, and obviously, the more we understand and the more studies we have, the more we can actually advise on that. But I think this is the most current one, and essentially about half an hour a day for 5 days a week of moderate activity, of low intensity activity. So it's all right for all individuals with arrhythmogenic cardiomyopathy, and then some of the individuals who have very low risk with no risk factors as we've seen them before. So they probably are okay to exercise a bit more, again, to moderate activity. Now, what is light activity? So this is about, this, as we said, 2.5 hours of about light running or, brisk walking if you want. And if you're on a treadmill, which makes things a bit easier to control, it's about 4 miles an hour on the treadmill. So really, it's brisk walking, essentially, where you can, walk and lead a full conversation at the same time. So that's the amount of activity that everybody can do, and potentially some of the low-risk people may be a bit more than that. Yeah, and this slide is more intended for studying that afterwards, and it tells you essentially, how what the effect is of the exercise on the different types of sport disciplines. And obviously, how high the intensity is and how frequently people are allowed to do that. And you can see we're probably somewhere in this area, yeah, that we should stick. Really, the competitive exercise, high intensity endurance exercise is really not recommended to in individuals with arrhythmogenic cardiomyopathy. And in fact, this is also true for gene carriers, so relatives who have no cardiomyopathy yet, but they are gene carriers. Yeah. Heart failure is a bit of under-recognized, so essentially the inability of the heart to pump the oxygen to the body and the blood. But we know it can happen, especially in people who have more affected the left side of the heart. Symptoms are, those of heart failure. Really, they're very similar to what people with dilated and heart failure and cardiomyopathy will experience. But it's not common that people with isolated right ventricular cardiomyopathy will need a transplantation. I don't think we actually have the data at the moment to say how much of those is in the general arrhythmogenic cardiomyopathy, because as I said, there's a lot of overlap with dilated cardiomyopathy. At the moment, we're not going to be, or we're not there yet to actually know what the numbers are. But always think that on the right ventricular, isolated right ventricular cardiomyopathy, it's heart failure is rarer than with those that have left dominant. And again, going back to phenotypes. That may be another thing to discuss very briefly. So ablation, for some of the ventricular arrhythmias may be very persistent. We tend to treat them and do a lot of things. And obviously, the defibrillator will protect people from from cardiac arrest. But we don't really want somebody to have shocks all the time, or we don't really want anybody to have any shock. So if the arrhythmias tend to come back, then sometimes we will offer a VT ablation to patients, so essentially going with some wires to the heart, monitor where the actual rhythm issues come from, and potentially treat them there with by burning away the focus. So that's a very common and very effective way of treating that. You can see here we can reduce the symptoms as well as the risk of having shock from the device. And I think I'll close the first part with this one, which is essentially what the treatment recommendations currently are, which is stop exercising really. Some people are going to be very happy, but most of the people are not very happy about it. It doesn't mean you need to stop completely exercising, but it just means we need to avoid the high level, the endurance, the high intensity in competitive sports. And for some individuals, it may be possible to actually have a bit more exercise, but for everybody, really, about half an hour of brisk walking a day for 5 days a week is fine. Beta blockers, take beta blockers. Quite often we recommend them because they prevent the arrhythmias. So it's really, some people actually believe everybody should have it, but generally people with arrhythmia should have it. If the left side of the heart is affected as well, then really we're going into treatment for other forms of heart failure, if you want. So ACE inhibitors, some of the newer medication, and Entresto. So quite a lot of those things that we recommend. If the arrhythmias get too hard to deal with, then we may recommend some additional medication like amiodarone, sotalol, flecainide. And we know that these are quite effective medication, or potentially go to more aggressive and intense treatments. And obviously, always think about the ICD. Yeah. Last bit is about the family, and I think obviously that's one of the other very important parts of our job, is really not only treating the individual but having a look at the family, because we know it's most of them are going to be 50-50 chance of passing the gene on. So really screening is recommended for every first-degree relative, every 1 to 3 years. Again, we will decide depending on what the genetic condition in the family is. Some of the high-risk genes, we end up seeing people more often than not. And then usually same amount of investigations, the same type of investigations as in people with arrhythmogenic cardiomyopathy. So ECG, Holter, echo is absolutely necessary. Sometimes we may end up with a stress test or a cardiac MRI. In fact, quite often we will do a cardiac MRI as well. And a bit about future. I mean, thankfully, we've got a lot of research going in there. So there's people looking into what the actual inflammation is doing in the heart. So we know that actually inflammation in the heart, and we discussed about myocarditis, and we'll come back to that in a moment, seems to be integral part of actually the progression. And we know that if we actually stop the inflammation in the heart, then sometimes actually we can prevent a lot of the damage that is happening there. So there's a lot of different medications that are being trialed out in terms of reducing the heart inflammation and that. And I'm sure we're going to see some positive results soon. And obviously, there's gene therapy coming up at some point, but I think we're quite far away from that. So I think that I'll stop on that with that bit, and I'm sure you're going to have some questions later. If that's all right, I'll move to the myocarditis bit. All right. So now, lots of information until now. Feel free to go grab some water, some coffee, and then I'll just crack on. Yeah. So if myocarditis, what it is about, it's really about an inflammation. So it's, you're getting inflammation in the heart, and that you can see on both your investigations. But more importantly, you need some histology there. So you need to actually look in the heart directly and see whether the heart is inflamed. And we've got various ways of doing that. And why is inflammation? What is inflammation doing? Essentially, it can lead to an enlargement and weakening of the heart muscle. And the heart, it can get scar tissue. It needs to work hard. So, developing symptoms of heart failure, if you want, or a condition that we know as dilated cardiomyopathy, which we discussed before. And again, always very difficult to actually find, for these type of conditions, how common they are. And if you look into various different populations, like in infants and childhood, it tends to be quite common. In some young athletes, again, myocarditis tend to be quite common as well. If you look in the general population, it's probably not as common. But you can also see here that the amount of myocarditis that we think is going around, it tends to increase over the years, which probably means that we just recognize it a bit more than we were doing before. So it's more common in men. Men are not really happy about it. DCM is also more common in men than in females. And it can affect anyone, really. In fact, it probably affects more young athletic individuals, children and infants. Yeah. And as I said, we do recognize it much more. 1950, a few publications on PubMed, and in 2023, we've got about 10 times more than then. Maybe we just recognize it because, there's people that are affected with that we know, and we see that a bit more often. Presentation is really, I think that's one of the most important bits. It can sort of have lots of various and different ways that, that people present with. I think one of the most common ones is probably when people present with chest pain, but they've got normal heart arteries on the angiogram. So that's the most common presentation. But then, some people present at later stages where they've already developed a dilated cardiomyopathy, and when we actually look in the heart, we'll find some inflammation and tell them they've got myocarditis. Some people present very acutely unwell with what we call a fulminant myocarditis. So they're generally very unwell. They will end up being supported with a lot of medication and mechanical support. And some people actually may present with a sudden death to start with. Causes, there are lots. I'm sure this slide is probably not complete, and every time we can add more. But in general, we're saying there's a lot of viruses, especially in the, in our place of the earth. There's a lot of viruses that happening. In other places, like Brazil, you can see a lot of trypanosoma, so more protozoal, and obviously parasitic and bacterial infections. And then there's a lot of non-infectious causes, like when you got a systemic inflammatory condition, like a giant cell myocarditis, or you got a sarcoidosis, or you got lupus. So that can be part, so myocarditis can be part of that system. And there's some medication also that can do that, also. Some of the novel chemotherapy drugs as well can cause myocarditis. And this is our understanding over the years. We started back there, we're seeing a lot of influenza, some Coxsackie viruses. So most of our research really comes from, from these ages back there where we were seeing a lot of Coxsackie virus. And now obviously we've reached the the COVID level and COVID stage, and we don't see that much anymore of that. We may see a bit of COVID. We think parvovirus maybe, so other viruses may be more important at this stage. And really, most of our understanding does come from from mouse models. So there's a lot of mouse models because it's been very difficult, and it is very difficult quite often to actually see what is going in the human heart. And hence, we need some other way of finding out what's happening. And this is what's happening, or what we think is happening, really, with myocarditis. So, there's some trigger to start with. It may be a virus, it may be a medication, maybe something. And essentially what it does, it sensitizes our body, and our body overreacts to what it's being sensitized with. And then it, pushes a very hard immune reaction, inflammatory response. This goes in the heart, has a lot of inflammation. And people that can fight it very well, they will have a very little symptoms, and then they will have a complete healing process. So the immune system will go up, then it will come down. But some other people will have a sort of a chronic disease, if you want, where the immune system goes up, and stays there because we can't really get it down. Now, as we said, there's one of the triggers can be really inherited conditions. Some of we see myocarditis in quite a lot of them, even in hypertrophic cardiomyopathy, in arrhythmogenic cardiomyopathy, and we think the trigger there is really one of the genetic conditions and potentially something else as well. And this sensitizes our body and produces this inflammatory response, which in turn we may be able to work on in the future. Classic symptoms, as we said, chest pain, shortness of breath, especially after exercise or when lying down, lightheaded, swelling, and sudden loss of consciousness or even cardiac arrest, obviously. We do, cardiology is not really very imaginative. We're doing the same amount of tests. We've got an ECG, we've got a chest X-ray, lots of cardiac MRIs and echoes and bloods and everything. And I think that's probably what is different from others, from other conditions, that we quite often we will need to go to get to the bottom of the heart, actually, to look into that and see, what's going on there. Is there inflammation in there? So cardiac biopsies are going with a small forceps in the heart and taking small pieces of muscle out. It may be necessary. And thankfully, our imaging, you can see here our different imaging modalities can go very, very deep down, almost to the cell level, especially if you look into the PET scans that we nowadays can do. So it can tell us a lot about, there's a lot of inflammation in the heart, but we will quite often need to go to a biopsy to actually find out if there's a virus in there, what type of inflammation we actually have, and this is relevant. Now this is how the cardiac MRI is going to look like, and remember, what we saw before for the arrhythmogenic cardiomyopathy. But here you can see this is whiter than the rest of the gray heart. So this is where the swelling is. You can see it's also thicker. So the heart is really swollen from the inflammation, the way we know it from other places in our body. And you can see here there's a bit of sort of inflammation, which is quite patchy on the outside side of the heart. So quite often it starts there. Now the PET scan it will give us much nicer pictures in terms of the heart is lighting up there. So all that lights up, we think it's inflammatory cells. So essentially we give sugar. Our immune cells like sugar a lot, and then we can actually image that on a PET scan and see that where the heart inflammation is. And as we said, the biopsy is important because we've got lots of different types of myocarditis, but some of them they don't really need treatment. Some of them we can just let them go and get healed by themselves. And this is what we normally do. But some of them, they will be more important, and it's important to know if for instance, if a giant cell myocarditis or a sarcoid one, we will need to help with treatment. And again, this is why the presentation is very important. So people who present with and are acutely unwell, they tend to do worse. So people who present with a sort of less common, with more of a chest pain, but they tend to progress very less, to have a better prognosis essentially. And this is why the actual type of inflammation is very important. So if you see one of the worst prognosis is with a giant cell myocarditis, and then we've got the eosinophilic, so different forms of myocarditis which are potentially not as bad as the other ones. So it's really very important to actually try and understand what's going in the heart itself. So I think most cases are really self-limited, so they will lead to complete healing and resolution. But about 1/3 of the patients may develop this condition that we call dilated cardiomyopathy, which is sort of a heart failure phase. And we know that about 45% of the heart transplants that are happening in the US at the moment may be due to, or are thought to be secondary to myocarditis. It can come again, but generally not so frequently. And again, it's probably self-healing. And I'm going to talk to you a bit about the giant cell, which is with myocarditis, which is pretty rare, so very, very rare. But it is quite significant inflammation of the heart, and it often is associated with a very bad prognosis. So important to diagnose early on, and obviously to treat appropriately. A bit about COVID. A lot has been said about COVID and how common it is. But really, we see a bit, and it's usually self-limiting. So I don't think we can say with confidence that COVID is doing particularly bad myocarditis at this stage, or the vaccines. Yeah. So and I put this slide just to say that COVID-related myocarditis, we've read a lot about in the papers and everything. It's very rare, really. And typically it occurs in men, young men, 20s, very frequently in the first few days after the vaccine. It's a very self-limited disease, so very good prognosis essentially, and leads to complete resolution. There are some case reports of more severe complications, but generally they're very rare. So, I don't think we need to be particularly worried about this type. Get treatment with, what we do is support really the heart to improve the inflammation by itself most of the times. So that we'll give some of the classic medication for heart failure, which we know that reduce the inflammation and improve the heart. But in some specific forms, which we need to find out really, the giant cell and the sarcoid and the eosinophilic, and some of obviously of when something is happening in the whole body, then specific medication will need to be given with steroids and potentially other medication as well. And sometimes when we think the virus is, that's directly the problem there, then we may end up actually suggesting an antiviral medication. But I think that's probably a more rare occasion. Exercise, again, going back to that, very, very important. And in general, what we say is that, again, here exercise is really, bad for you in the first 3 to 6 months. So in the acute situation, you shouldn't really exercise intensely after a myocarditis episode, and afterwards you can probably go back to that. And what we will need to assess is obviously if there are any high-risk features. So people who have a complete resolution, no arrhythmias, they can get a stress test and everything is fine, then they can go back to full exercise. In fact, even competitive athletes can go back to competitive exercising. But people that end up having a lot of persistence of inflammation in the heart or a lot of scar tissue after the myocarditis, then they probably will have to avoid high-intensity competitive sports. But thankfully, this is going to be only the very, very small minority of patients after a myocarditis. So I think, just to conclude on that, myocarditis is very diverse, really. You see there's lots of causes, and, we've got many different ways of finding out what the problem is and treating it, and, usually we'll have to come to get to the bottom of that. It is usually associated with a good prognosis, as we said, so most of the times we're just supporting and not doing anything more than that, and essentially we help the heart recover. Some of the patients with acute disease or some high-risk features, they may need extra support, like steroids. And definitely important to find these 2-3 types of myocarditis, which are very rare, thankfully, but we can treat them very well differently, and it's very important. I think that's probably what we said about the viruses and the immunosuppression. There are some novel treatments coming up, which may actually be more important for stopping the progression of the condition. That was my last slide, actually. Surprisingly on time. Thank you so much for listening and not falling asleep, more importantly.
I just want to ask regarding the exercise.
No surprises there. I was expecting it's going to be the first question.
You said about the low exercise and high exercise and all. Is there the restriction of the exercise tolerance depending upon the type of the cardiomyopathy? One. The second thing is, can we, if a patient comes and we ask, my ejection fraction is 20, how much exercise I can do? My ejection fraction is 40, how much I can do? Is there a correlation we can give to them? Two things. Thank you.
Yeah, so thanks. I think that's a very important point, that don't get me wrong, the answer is going to be, we don't really have clear recommendations on most of the types of cardiomyopathy. So when it comes down to arrhythmogenic cardiomyopathy, all of the data that I've shown to you, we've got a lot of data on patients who have right ventricular cardiomyopathy, so patients that are affected in the right side of the heart. And more importantly, patients that almost certainly have plakophilin mutations, so in a specific gene changes. So for those patients, we know doing a lot of exercise, doing more exercise is going to make things worse. Yeah. So, and this is what we can tell about that. Now, because there's a very large degree of overlap between what we call arrhythmogenic cardiomyopathy and a dilated cardiomyopathy, so the things get a bit more messy there. Yeah. So, obviously the general recommendation will be that for anybody that has been told that they've got arrhythmogenic cardiomyopathy, they should keep their exercise at a level to a low, potentially moderate level of activity in order to avoid both this disease progression, but more importantly, the dangerous rhythm issues. So I think that's true for it doesn't matter, you know, what sort of arrhythmogenic cardiomyopathy you have. You need to limit your exercise activity. Now, the impaired left ventricular systolic function is obviously is obviously part of, you know, our risk assessment, and somebody who has significant impairment of the pumping function, they're going to be at higher risk than people that have normal and preserved function. As I saw, you know, it's part of our risk assessment. So let's say, you know, if you're coming to me and telling me that, you know, you've been diagnosed with arrhythmogenic cardiomyopathy, but you've got a normal left and right ventricular function, then you're probably lower risk than somebody else that has a 20% ejection fraction. And this will apply also to the exercise advice that we're going to be giving. Now, whether you're going to be able to say, you know, between the 20 and the 40%, I don't think it makes much of a big difference, let's put it like that. But in any case, the advice is going to be avoid the high intensity endurance exercise. And then really it's the difference between, you know, are you allowed to do moderate a bit more exercise than the low that is, you know, is allowed in everybody. And I think there you will need probably a bit more than 40% ejection fraction to actually do that. But again, what I don't want you to take out of that, and because, you know, there's, I mean, even, you know, in people who are not specialized in that, you know, even cardiologists, it's not very well defined. So let's say that you're coming to me and you're telling me you've got dilated cardiomyopathy, you know, and how much can I exercise with a 40%? So, you know, there's a very large degree of overlap, but this is only applies to people that have arrhythmogenic cardiomyopathy. Yeah. So people with dilated cardiomyopathy, for instance, you know, some of the low risk genes, they may be able to exercise a bit more. Yeah.
I think it's a very wonderful, very comprehensive talk, very resourceful, and a lot of very relevant and pertinent to arrhythmogenic cardiomyopathy. I just like to inquire, right? If those patients with rhythm issues, they might not fall in the category of myocarditis. Most of them are idiopathic. They have cardiomyopathy, not sure for what reason, and they have low ejection fraction. But there is a significant relationship with arrhythmias. They have maybe ventricular, atrial tachycardia, perhaps, or supraventricular tachycardia, and it happens recurrent for no reason after extensive investigation. Where does this nomenclature come into? Does it come into this arrhythmogenic cardiomyopathy, because it was not really covered in part, because it was more like what covered in the lecture is more on the genetic or the autoimmune, and there are many cases that they have not come to a proper diagnosis. It's a general arrhythmia, and following that they have tachycardia-induced cardiomyopathy, and it's potentially reversible with beta blocker and ACE inhibitor.
Yes. So I think if I understand correct, the question is you're talking about specific patients that may have a lot of rhythm issues that lead to an impairment of the pumping function. Is that the patient that you're referring to? Yeah. So let's start a bit different. You know, the arrhythmogenic cardiomyopathy has a very well defined, you know, phenotype in how it looks like. So you need scar tissue in the heart, and you need fat tissue in the heart, and you need electrical abnormality. So, you know, you need lots of things to actually, you know, diagnose an arrhythmogenic cardiomyopathy, which, you know, sometimes makes it very easy, you know, when we got a lot of findings there, or it may be a bit more difficult, as I saw, you know, on the pretty extensive table sometimes. So, but, you know, generally the phenotype is very well defined. So, and you will need, you know, some of those features. Now, the type of condition, you know, that you're talking about is usually one where the heart starts, you know, what the heart doesn't like is an irregular and fast heart rates for no reason. You know, so if you've got something that, you know, does like that, eventually it will it will lead to some sort of pumping dysfunction, because the heart may get tired. Yeah. Now, the way we treat this type of conditions is usually trying and suppress the arrhythmias and see if the heart recovers. And obviously you will need to have people will need to have extensive investigations, which may involve, obviously, you know, cardiac MRI scans to see if there's scar tissue in the heart, genetic testing, you know, check the family to see if somebody else has, very similar. So, family may be quite important, actually, diagnostic, part of that. And if all these things are, don't lead us to any conclusion, then, we treat, symptoms and really the impairment of the heart function. But I don't think we can actually label that type of condition as an arrhythmogenic cardiomyopathy per se, if you want. Yeah. So I don't think it quite falls in that area or in that category. So we've got a special name for it, what's called tachycardia-myopathy. I think you may have heard that, which means that the heart is very fast for no reason, and it tends to dysfunction. Again, extensive investigations will show whether what the risk of people is, but quite often, and as in everything in life, it's nothing is 100%. And unfortunately, medicine is we understand a lot, much more than what we used to understand back when Hippocrates started, but we're not quite there yet, and there's a lot of things that we still need to understand and find out. And quite often we're limited by what we can actually find out. Obviously you've seen biopsies. If you have, a mole somewhere on the skin, what the first thing you're going to do is take it out and, look it up under the microscope and see, is that dangerous or not dangerous? But with the heart, it's obviously, well protected in the chest. Alex can get very, very easily to it, but, we are a bit more limited to do that with biopsies. And quite often, it's obviously more dangerous than actually treating the disease itself. I don't know if this answers the question, but I think I don't think you can call arrhythmogenic cardiomyopathy this type of condition unless obviously you've done investigations and you found signs and symptoms that are in keeping with it. Yeah.
Thanks very much for the presentation. So my question is for a particularly young person, i.e. a 9-year-old, filamin C gene. How would you suggest exercise restriction even at that age, or can they participate in normal sports and that through to sort of teenage years? How soon would they look to start that? Yeah,
so I think that's one of the areas where we probably need a bit more work to do. Because obviously the filamin C gene as a cardiomyopathy and a heart muscle condition has been relatively recently described. We know about it in 5, 6, 7 years ago, in the way that we come to realize that is part of the arrhythmogenic phenotypes. And as I said, most of the exercise advice that we're talking about does not apply to filamin C. Yeah? So generally, in this type of questions, what we do is assess the risk. Yeah. And then the risk we do with various investigations. So if somebody is a gene carrier, I don't think they're being a gene carrier with filamin C probably doesn't mean that if you exercise on a moderate level, probably it's going to do you any harm. If everything, all the investigations are normal. So this means if you got a normal Holter, if you got a normal stress test, and you got a normal cardiac MRI scan with no scar tissue and normal echo, obviously, and no symptoms, more importantly, then I don't think you should limit the exercise level particularly. I think my inclination would be to say that obviously competitive and high endurance sports are probably out of the discussion, but I don't think we actually have the data to actually say that this is the case, and we know and more importantly, it probably will stop the arrhythmic events, or the risk of dangerous rhythm issues, but probably will have nothing to do with the progression, because filamin C works in a bit of a different way than the other genetic conditions. So all in all, what I would say is that if all investigations are entirely normal and we don't have any worries about that, and the child has no symptoms, then probably it's okay for them to have a relatively usual exercise activity at school with close follow-up, obviously, but avoid the high intensity and endurance sports. I think, but again.
So sprinting, for example, like running, is that?
I think usual school activity. I would say, if they're trying to break the world records for schools, probably not. But again, they will have to go through extensive investigations. Yeah.
I probably don't need this actually, because I've been called quite loud.
Yeah.
But thank you for your presentation. I would just wanted to know a bit more about ablations in terms of a treatment plan.
Sure.
And is the likely, because it's a very effective treatment, but I'm just wondering, would that cause sort of scar tissue, and then as the condition progresses, are you more likely to have to, or are there other alternatives to the ablations?
Sure, yeah.
Thank you.
Yeah, so the ablation is a very effective procedure to treat arrhythmias, that are generally resistant to other forms of treatments. I mean, obviously, it's a very invasive form of treating something, so you really want to avoid going into that stage if you can. So, if you can suppress the arrhythmias with medication, with potentially with, even more advanced antiarrhythmics, then that's probably, the way to do that. Now, so usually ablation is reserved as a last stage, if you want, where, and this is reserved for patients that despite all sort of medication, they will still experience arrhythmias, they will still have shocks from their device, so, where really the quality of life is important. And in those cases, I mean, usually what we do is we put the wires in the heart, we do an ablation from inside, quite often, and in arrhythmogenic cardiomyopathy, we will need an epicardial approach, so this means we will have to go under the chest bones and actually check the outside of the heart as well, because that's usually where the whole rhythm issues occur with arrhythmogenic cardiomyopathy. And obviously we are limited by the amount of times we can do that, because every time we actually go in there, it will cause some scar tissue and some inflammation. Yeah. So again, careful selection of patients is important there. Now, you're absolutely right. It tends to be progressive condition. So even doing an ablation doesn't mean that it will not come back, after a while, as potentially new scar tissue may develop or a different channel. But quite often it does what we want it to do, and for quite a while, it will settle the symptoms, and I think that's the important bit. It's not a cure, but it will treat the symptoms very well. The other thing that is probably relevant for that is that, with arrhythmogenic cardiomyopathy, early on when there is a lot of, healthy tissue, if you want, so the problem with these arrhythmias, the rhythm problems, they occur when there's healthy, patches or islands of health tissue among scar tissue. Because the arrhythmias, they just circle around scar tissue. That's what they do. And quite often, in the early stages where, there is a lot of health tissue still around, then the rhythm issues are going to be more. At later stages where there's going to be a lot of scar tissue everywhere, then probably the rhythm are going to settle down again. So that may be also something to think about with ablations and stuff. So they tend to be more needed potentially earlier on in stages, but less so in later stages.
Thank you very much. Really interesting talk. I've got quite a few questions, but I've got two around medication. And the first one, we heard from Ruth in the opening session that there is a relatively new drug for DCM, which apparently has very good results. And I wonder, given that you're talking about the amount of overlap between DCM and AVC, if that's applicable to AVC. And the second one is more general, and the news over the summer about the Cure Heart project was really fantastic for me with my condition, and my kids both have inherited it, and I'm sure for many others in the room. And I just wondered if you could, I've seen the videos that are available on the BHF website, but I just wondered if you could go into a bit more detail about what that's about and what you think about how those sorts of treatments might progress in the future.
Sure.
Thank you.
So on your first point, I suspect you're talking about the dapagliflozin, the diabetes medication. Yeah, so there are quite a, obviously there are a couple of new medications on the market. One is, or at least, for patients with dilated cardiomyopathy, we're talking about dapagliflozin or empagliflozin. So there's some, people have used it for a long time for diabetes. Essentially what it does, it makes you pass a lot of sugar out in your urine. And by this mechanism, it just reduces the amount of blood sugar. Yeah. Now, what we found out recently is actually that even in patients who have not diabetes, and even in patients that actually have nothing to do with heart arteries, like dilated cardiomyopathy, essentially, it tends to be very effective in actually improving both the longevity of the patients, but also the potential complications in terms of admission to hospitals with heart failure symptoms and all this stuff. As you can imagine, no one is we don't have really the data at the moment whether this applies to arrhythmogenic cardiomyopathy, because there's no particular, there's no specific trial on that. But extrapolating the data, and because quite a lot of the mechanisms and the pathways that are involved in the arrhythmogenic cardiomyopathy, they will be part of the general heart failure as well. So I would assume, or we quite often use it in patients who have the left side of the heart affected. Yeah? So patients who have involvement of the left ventricle, they will be candidates and should really be on the best possible medication for heart failure, the way we do it for other forms. Now, the data on isolated right ventricular cardiomyopathy are probably, well, they're certainly not there, so we don't have them. If we want to extrapolate from what other medications are effective in isolated right ventricular cardiomyopathy, where we really haven't got any medication that actually does anything that we want them to do, I would assume that potentially maybe not, but again, not much information on that. Now, I mean, obviously the Cure Heart project, I mean, obviously in Oxford, it's all about potential gene therapy development. We're all very excited. Obviously we need to understand a lot about how genes work and what genes are specifically doing, and then we will have to focus on individual genes in a way, if you want. And obviously not every gene is going to be effective, in having a genetic treatment in terms of gene therapy. But the ways, how the many different ways of how you go around, around that. And some of the genetic, especially most of the conditions that we're talking about, arrhythmogenic cardiomyopathy, is really a protein cut short, and there's a lot of protein that is not being produced, which potentially cause a lot of inflammation. So potentially, theoretically, if you actually replenish that, by actually a gene therapy, it may be easier to actually treat things. Yeah? But the question is, will it go to the right place? So there's, I think there's a lot of questions on that, and probably it's going to be a bit more complex. But I think, for conditions like maybe hypertrophic cardiomyopathy, which, it's a bit simpler in terms of, how the pathway works. It may be more easier to do, maybe even for, for conditions like dilated cardiomyopathy and, specific things. And obviously, we just need to find out whether it's going to be the case for more specific genes in arrhythmogenic cardiomyopathy. As I don't think we're quite there yet to talk about, gene therapy in most of the conditions. I mean, at the moment, we've got gene therapy for some conditions, and there's a lot of trials going around, quite early on. They usually focus on relatively single gene changes, or where one single nucleotide, so one single piece of the condition is changed, in which case we can actually skip that, for instance, like exon skipping therapies, where they essentially, instead of causing a complete destruction of the protein, we just create a bit of a shorter and improve the phenotype. These are ways to work around it. So it will be very individualized, essentially, and very genetic oriented. I don't think we can actually say at the moment what they are. But it will give us, obviously, it's very important to get the whole understanding about it.
There were sort of two elements that I saw in BHF, and I don't understand genetics, so but one that was being talked about that I thought might be simple was something about suppressing the expression of genes. And then the second sort of more advanced one was a CRISPR version.
Yeah. Again, that's exactly it. So depending on the genetic change, you've got different ways of doing that. So CRISPR essentially is just recreating a gene, or just changing and trying to make a genetic change, get back to the normal one. Yeah. So editing, if you want, like gene editing. Yeah. And suppressing the function is when you have. So for instance, it doesn't quite apply much in cardiomyopathy. In some forms it does. So we know that some forms may produce proteins that are a bit deleterious. So have adverse effects on the myocardium, and these are actually a bit easier to treat, because actually you can give one of the small molecule targets which can suppress the expression of those genes. So these are a bit, but it doesn't quite apply to all of them. And actually most of them are are not really the way. Most of the cardiomyopathies that we deal with in here, it's really about having a shortage of proteins rather than actually having an adverse effect. In hypertrophic cardiomyopathy, we do have a couple of causes where we actually think that the change protein has adverse effects, and which may be a bit easier to do, but not quite in this type of conditions. Yeah.
Hi, thanks again for your talk. I just wondered if you could talk a little bit about the challenges in diagnosing between something like ARVC and cardiac sarcoidosis, and how the treatment and prognosis would differ, especially if the deterioration is rapid.
Yeah. Yeah. So I mean, with just for the rest of the people, I guess the arrhythmogenic cardiomyopathy we're talking about genetic condition. Sarcoidosis is an inflammatory condition of the heart. So we'll go to the second part of my talk essentially. But quite often the changes that it causes in the heart are very difficult to differentiate. When we look into the heart and we see how it looks like, and quite often it's very difficult to differentiate one from the other. Now I think important is, as always, is the diagnosis, and this is what defines obviously the treatment that you're gonna choose. So essentially, if you're gonna go or people go through all various investigations, which potentially will include a biopsy, genetic testing, cardiac MRI scan, an FDG PET scan, and obviously other things. And if all of those are very inconclusive and there's no extra cardiac manifestations of the cardiac sarcoidosis, then I think it's going to be very difficult to differentiate both of them. Thankfully, we've got some medications that work in both, which is essentially the ACE inhibitors and the classic heart failure medication that we use. But if we don't have any evidence, so in essence, we have to have a proper diagnosis. I think that's the important thing. Yeah. So which may involve a biopsy of the heart. So if you do find sarcoid in the heart, then you will have to treat it differently. And the treatment there will be central immunosuppression, essentially, which is going to be part of that, and this will define also the prognosis. As in quite a few things, when you start treating early on, then your chances of being successful, on the later stages is probably better. Yeah. And you can potentially stop the progression. I mean, with the sarcoid itself, it does go quiet after a few years anyway. So if you actually manage to suppress it, at an early stage, then we think that the long-term prognosis actually may be better. Yeah. But obviously, with arrhythmogenic cardiomyopathy, it's a bit different. Immunosuppression doesn't quite work. So yeah, it's tricky. But as always, you just need to find out what you're treating. And I think that's what defines the prognosis and the success potentially as well. I don't know if I'm covering that. Probably not particularly, but I think it's it's important to actually have that knowledge of what you're treating. But it can be very difficult to differentiate quite often. Yeah. So.
Thank you. I just wanted to clarify something around family screening. If the siblings of an affected young person, if they are not found to have the gene, do they not need any further follow-up, or did you say they should be followed up every 1 to 3 years? No,
so no, you're right. I mean, we're talking about predictive screening. Essentially, if we have a family when we've got a known gene in the family and the first-degree relatives have been tested against that gene and they're found not to be gene carriers, then we generally are able to say that they don't need ongoing follow-up. Having said that, with arrhythmogenic cardiomyopathy, as you can see, quite often the genetic background can be very complex. And also, we may not be able to say 100% certain whether this is the only gene that is in the family, because we know there's other things that come in role. So quite often, if we do find that there is, relatives are not carriers of that, we may recommend a looser follow-up, if you want, every 5 years instead of 1 to 3 years. But I think it has to be individualized. For most of the genetic conditions, we're absolutely certain that this is the genetic change that causes the condition in the family, then we're able to discharge people from follow-up. But sometimes it can be complex, though, yeah?
I have a question just following on from that. So thinking of somebody that's had a negative genetic screen quite a few years ago, but is now in a very, very physical job. Now, I was told that some of the blood was kept back and will be retested from time to time. Now, this was going back a lot of years now, and it only just occurred to me when that lady was talking and thinking about the exercise type of things. So, yes, so this person has sort of dropped off the radar unless they develop any symptoms. So in light of what you're saying, if that is the case, what's the way forward in terms of saying, look, you know, new genes may have been discovered. There's a positive family history.
I assume this is a family relative, not an affected person, isn't it?
A relative.
A relative, yes.
A relative.
Yeah. So the way the predictive testing works is you test the affected individual in the family. If you find a gene, then you can use it to test the rest of the family. Now, this is the good scenario where you actually find the genetic change where, you know, we are certain this is the disease-causing gene, if you want. And in those cases only, we are able to discharge people. If we don't find the gene, because, I mean, we recognize our knowledge, obviously, it is as it is. You know, imagine we're testing for 40 genes and we know we've got about 20,000 genes plus a lot of things that we don't know about. So in those occasions, we will not discharge the patient, the relative. So in those cases, the relative should have ongoing follow-up. So they, you know, theoretically, they should be seen every, 2 to 3 years. Now, from time to time, obviously, if the genetic testing on the affected individual happened, many, many years ago, and in the meantime, we've got some new genes, we go back and retest the material that we may have from the affected individual, and then we can potentially reassess. But hopefully, by that time, all individuals will have remained under follow-up anyway, and not dropping off radar. Yeah. But generally, we will only discharge a person when we're certain about a gene, and the person is not a carrier. And obviously, quite often we'll go back and reassess. I mean, for instance, for hypertrophic cardiomyopathy in the last 20 years, 40 years, we have done some change, but we're not really picking up much more. We've got a few more genes coming up, but generally our yield of genetic testing is about the same. It's not the same about dilated cardiomyopathy and arrhythmogenic cardiomyopathy, where we have much more, and quite often we go back and repeat the investigations and the tests.
Thank you. We have time for just one more question. We've just got about 4 minutes remaining. Are there any other questions?
It's a bit more general, really, but I'm from the Children's Heart Federation, and we alert new parents to the signs that their baby might have a heart condition. But I'm wondering about, we're talking about the sudden deaths among teenagers and adolescents. Are there any signs that we could alert maybe even sports teachers and coaches to, that, one of these young people may have a cardiomyopathy? Are there any? I had heard that sometimes they faint.
Yeah.
And that sort of thing.
Sure. I think what is very important is obviously the family history here. So if there is a family history, then obviously symptoms like fainting, palpitations, chest pain, shortness of breath are really red alerts for the child, who hopefully will be under regular screening anyway. Now, in the general population, again, the same symptoms are relevant, and they should prompt investigation, appropriate investigation, obviously. And quite often we do find really, it's not always the adults that present as first, it's really the children that present as first, yeah. But it becomes much more tricky to be talking about the general population. Now, as our understanding of things and as our, obviously sensitization in the subject, becomes more, people tend to screen more and more. And at the moment, there are programs, where schools potentially are getting screened as well, especially, for children who are highly athletic. I mean, obviously, the children that participate in competitive sports, they will have screening as well through their clubs, or at least, you know, it is recommended that they do that, and, you know, there will be, you know, things to pick up there. So I think that's probably things that we can, you know, recommend. And but the limitations of screening are well known, and obviously, if you screen somebody in the general population, you may or may not find something. It doesn't quite tell you that, you know, this person is never going to develop something. So, you know, we pick up things, but unfortunately, not everything. But I don't think we can advise anything more other than, you know, be, you know, prompt with investigations if there are symptoms in the family, and potentially engage in screening, especially when there's high degree of athleticism there.
Thank you.
Unfortunately, we've come to the end of this session, so I would like to thank Kostas very much for giving up his Saturday morning and giving us a very interesting and informative talk